I wish I could say I came up with that snappy little acronym, but actually it came from an editorial in the British Journal of Sports Medicine in 2003. And unfortunately, 22 years later, not much has changed. So what does that acronym mean? Well, I'm going to get straight to the point in this video. If you have chronic pain, and please remember this discussion is about chronic pain only, and you think, I should get an ultrasound or an X-ray or an MRI to see what's going on in there, please do so with caution. Now, why do I say that? Well, there's four main reasons, but before I list those four things, I want to emphasize a big point, and that is I'm not trying to say all imaging is inappropriate. There are many reasons why imaging would be appropriate, so stick around to the end of the video and we're going to discuss what those things are. Okay, so what are the four reasons why most imaging for chronic pain is inappropriate? I'm going to list them first and then expound on each point after. All right, so number one, pathology is present in people without pain. Imaging findings like partial tendon tears and disc bulges, arthritis, they're just as common in people without pain as they are in people with pain, which makes it really difficult to say with certainty that these abnormalities are actually the cause of your pain. Point number two, pathology is still there after pain resolves. So if you see abnormalities on an MRI or an ultrasound or an X-ray, and you successfully go through conservative care, meaning without surgery, and you take imaging again, that partial tear, that meniscus tear, that disc herniation will likely still be there despite the fact that you don't have pain anymore, which again goes back to the original question, was that abnormality that you saw on the image really the cause of your pain? Point number three, findings on imaging are subjective opinions. So what do I mean by that? Well, if you get one radiologist to look at an MRI or an ultrasound of a rotator cuff, let's say, or a meniscus tear, and then you get another radiologist to look at the same image, they are probably going to have different opinions. All right, point number four, early imaging equates to worse outcomes. So this is probably the most important point. If you get early imaging of a body part that's giving you chronic pain, by and large, you will have worse clinical outcomes, meaning you're less likely to get out of pain and regain function. So let's take a look at each one of these factors, and at the end, I want to explain that not all imaging is bad, right? And we're going to outline some key factors where you definitely should get some imaging based on something that is painful. Okay, so let's start with the first point. Abnormalities that are seen on scans of people without pain. There are so many of these studies that we'll just have to limit it to a few. So let's start with lumbar MRIs. This systematic review in 2015 took data from 33 different studies totaling over 3,000 people who did not have low back pain. I'll repeat that. These are people with no low back pain symptoms. They took all the data showing the pathology on the low back MRIs and put them into age categories for us. That was convenient. So, for example, 50% of 40-year-olds who have no low back pain will show at least one disc bulge in their low back and yet have no symptoms. What this means is that if you're in your 40s and you have low back pain and you get an MRI and it shows that there's a disc bulge, how can you possibly know that that disc bulge is the source of your pain when 50% of people who are 40 years old with no low back pain whatsoever also have disc bulges? Feel free to pause the video and check the chart. Find your age in the column and then the specific MRI finding in the row, and this will show you how common these findings are in people your age who have no pain. All right, let's move on to shoulders. This paper in 2019 looked at people with pain in one shoulder, and they did an MRI, but at the same time, they took an MRI of the non-painful shoulder. They found that 93% of all the painful shoulders had a rotator cuff abnormality, but when they took an MRI of the same person's non-painful shoulder, they found that 89% of those non-painful shoulders also had a rotator cuff abnormality. Partial rotator cuff tendon tears, not statistically significant between the painful side and the non-painful side. In fact, almost across the board, no matter what the documented pathology was, it was almost identical to the non-painful shoulder in the same person, with the exception of being full thickness tears, which are ruptures. Okay, let's move on to the knee. This study found that both men and women with no knee pain and an average age of 44 years old, radiologists found 97% of the completely painless knees had abnormalities. 30% of them had meniscus tears, 50% of them had issues with their cartilage. And lastly, let's look at hip and labral tears. This study did a review of the studies on people with hip pain. Remember, these are people with pain now. And they found that the prevalence of labral tears in people with hip pain averages between 22 to 55%, depending on the study. Well, that sounds terrible to have a labral tear in your hip, right? Until you see studies like this that looked at men and women with an average age of 39 years old with absolutely no hip pain at all, and found that 69% of their non-painful hips had labral tears, more than the group that had hip pain. Now, there are many more studies like this on shoulders and knees and hips, and also necks and elbows and feet and hands and osteoarthritis, and the list goes on. The point is, when someone has chronic pain and they get an ultrasound or an MRI or an X-ray, and they're told that something is abnormal on their scan, how can anyone be sure that that abnormality is causing their pain when those abnormalities are extremely common in people with no pain? All right, so let's move on to the second point. If you have a partial tendon tear or a disc herniation on imaging, and you get rehab on that body part, and you get out of pain, that tear or that disc herniation will usually look the same on imaging after you recover. So here's a study looking at tennis elbow, which technically is tendon-generated pain. And the subjects in this study went through conservative care, which was either immobilization or a steroid injection, and they concluded, in general, the MRI changes persisted in the patients at follow-up after 6 weeks, despite clinical remission. So there was this divergence between clinical remission of pain and the imaging still looked the same. Here's a study looking at patellar tendon pain. Subjects were given a rehab program, and despite a large reduction in pain, the authors found structural properties in the dimensions of the patellar tendon on ultrasound tissue characterization did not change after 4 weeks of exercise for the athletes with patellar tendinopathy, despite an improvement in symptoms. And they go on to say, quote, "It seems that structural improvements are not required for a positive clinical outcome." Here's another study looking at Achilles tendinopathy. These people had their Achilles tendons evaluated by both MRI and ultrasound, and they went through a 12-week rehab program. In the end, they concluded clinical symptoms in early tendinopathy improved with physical rehabilitation. This clinical recovery occurred in the absence of any measurable structural alterations. And remember, that was with MRI and ultrasound. So we could go on, but let's take a look at low back and disc herniations. This review in 2017 looked at 12 other studies and found that over the course of a year, the vast majority of people with low back pain or sciatic symptoms will improve, but they found there is a lack of evidence on whether other MRI findings change and whether changes in MRI findings are associated with changes in clinical outcomes. So in other words, clinical outcomes like pain resolution is discordant with what you see on the MRI. So again, to review from the first point, abnormalities seen on ultrasound and MRI are very common in people with pain. But now, with the second point, we can also see that pathology on MRI or ultrasound is still there after the pain resolves from going through conservative care. And this is partial tears of tendons or meniscus tears or disc herniations. So it stands to reason that if the pain can resolve and the pathology is still there on MRI, what makes you think that that pathology was actually the cause of the pain to begin with? All right, so moving on to the third point, radiologists will have a hard time agreeing on certain things when it comes to the same image. Now, before I go any further, I do want to say that I have the utmost respect for radiologists because I rely on them heavily when I do order imaging, right? But they are human, and humans can look at the same image and have different interpretations. And this is particularly true when it comes to meniscus tears and rotator cuff tears. For example, this study found that when radiologists look at shoulder MRIs, they said there's good intra-observer reliability, meaning the same radiologist looking at the same MRI or ultrasound over and over again, they'll usually come to the same conclusion. However, there was also poor and fair inter-observer agreement results, meaning if you take the same image and have different radiologists look at it, there's poor to fair agreement in what they interpret. Now, another paper found the same thing when they had orthopedic surgeons read MRIs, and they said experienced orthopedic surgeons had good agreement for predicting full thickness tears. Now again, remember that means a rupture of the tendon, but poor agreement in predicting the grade of a partial thickness tear. Now, to be fair, this contrasts with the reliability of MRI readings for other tendinopathies like Achilles tendinopathy and gluteal tendinopathy, which do tend to show better inter-examiner reliability, meaning different, radiologists and orthopedic surgeons looking at the same image, they tend to agree better on Achilles and gluteal tendinopathies. Now, on to the fourth point I want to make, and this is probably the most important point, is that early imaging leads to worse outcomes. And this is why that editorial back in 2003 coined the term victims of modern imaging technology. So this was a systematic review of the available research studies on low back pain, and it's pretty clear that with all things being equal, early MRI of the low back results in worse outcomes. The authors point out that after looking at 7 different studies, all of the studies showed that subjects who receive early MRI for low back pain had an increased length of disability than those who did not receive early MRI. Now, how much of an increased length of disability, you ask? Well, 100 to 120 days longer, just because the subjects got an early MRI. Okay, so why is that? Why would an early MRI result in worse outcomes? Well, this is all explained in this 2021 paper titled Unintended Consequences, Quantifying Benefits, Iatrogenic Harms, and Downstream Cascade Costs of Musculoskeletal MRI in UK Primary Care. Now, that's a mouthful, right, for that title. But the term iatrogenic refers to a health problem that's caused unintentionally by medical treatment or a doctor's actions. In other words, healthcare gives you a new problem when you were trying to fix an old problem. And this paper does an outstanding job of reviewing this. In fact, it almost mirrors everything we've already covered in this video. They talk about how there's a high prevalence of findings on images of people with no pain, which includes the neck, the shoulders, the low back, the hips, the knees, the ankles, the feet. They note that early imaging is, quote, linked to greater disability and prolonged recovery, and it might cause low back pain to be more chronic simply because the imaging was ordered. So why is that? Well, findings can negatively affect patient perceptions, give people lower confidence in conservative management because people think, wow, my doctor must be thinking something is seriously wrong since they've ordered imaging. Early imaging also increases fear that exercise may worsen their condition, right? Because you see tendon tears and disc herniations and you're like, I need to not push this too hard. So people are less likely to exercise. It makes people feel a loss of control and an over-reliance on surgery because they're told that they have these tears and protrusions and bone spurs and all of the things that we saw earlier are just normal age-related findings. And all of that put together leads to poorer functional outcomes, while at the same time causing more distress, disability, and worse quality of life. The study goes on to say that because these findings pop up on imaging, it also leads to unnecessary surgical referrals. And they also touch on the idea that there isn't great agreement between radiologists when they look at the same imaging. The authors also go on to say that in their study, less than 5% of MRIs were actually warranted, less than 6% of the MRIs were unremarkable, which means that 94% of the time you're going to have something wrong on the image, even though these are just incidental findings. And lastly, primary care doctors in their study only read the MRI correctly and made the appropriate referral 16% of the time, and they were flat out wrong 70% of the time. Now, again, that's not to say that all imaging is a bad thing, right? There are definitely situations where imaging would be the right call, such as when pain is unresponsive to conservative care, you have unrelenting pain that doesn't go away with rest, unexplained weight loss that's associated with chronic pain, recent significant trauma, fever, history of cancer, severe or progressive neurologic deficits like numbness in the groin or the buttock, you have loss of bladder or bowel control, pain that's worse at night, or a recent bacterial infection, and there's some more, but I'm not going to bore you with them all. The point is, imaging does have a place, but in most cases for chronic pain, it tends to cause more confusion than it does clarity. So what's the takeaway here? Well, our MRIs and imaging certainly have a place for ruling out things like tumors and fractures in certain diseases, but they're not good at finding the specific reason for chronic pain conditions. In fact, the majority of findings on imaging, like bulging discs and arthritis and minor tears, are just things that we see on people with no pain at all. So once you go looking for something, you're likely to find it, whether it's relevant or not. So the old saying goes, a picture is worth 1,000 words, right? But if you're getting an ultrasound from someone who uses that ultrasound as a reason to give you surgery or an expensive injection, that picture may be worth more than 1,000 words. It may be worth a few $1,000s. And worse, it may not bring you any closer to the pain relief that you're looking for, right? Pain is a complex process, and imaging is just one small piece of the puzzle, one that often does more harm than good when it comes to chronic pain. Instead of focusing on the image, focus on what actually helps. Movement, strength, understanding that the pain does not always equal damage.